So I'm going to be talking, this has got, let me do my disclosures first. The title of this is Attention Deficit Disorder and Mania, What Should You Know and Why Should You Care? My disclosures are I get research money from Bristol Myers Squibb and GlaxoSmithKline, and I have been given, had my expenses paid and an honorarium to come and do this talk. So what I'm going to talk about today is a brief summary of ADHD, what I think you should know about phenomenology, course, and treatment. Bipolar disorder, and again, a quick update on phenomenology, course, and treatment. Why there's been confusion, because there is a good deal of confusion. And I'm going to talk a little bit about whether something called mood dysregulation is just another word for bipolar. And because there's some confusion between ADHD and bipolar disorder, the question is this some sort of Talmudic thing that the Great White Tower types obsess about, or are there some treatment implications? And then after I do my talk, I'm going to take a breather, and then my colleague Paul Grover from Stony Brook, who works with me, and I are going to talk a little bit about assessment in bipolar disorder in kids. So, this is Carlson's summary of ADHD. It's a heterogeneous condition. It comes in mild, moderate, and severe forms. Deficit doesn't mean none. It's one of the things that parents frequently come in and say to me, oh, my kid can't have attention deficit disorder. He or she can spend hours, playing video games or watching TV or doing Legos or whatever. Deficit does not mean none. It means that attention cannot be sustained when the child or adult doesn't have a real interest in what the topic or exercise is. And I tell people to think of the acronym HIDE. When you get old after a while, you just don't remember stuff, and so you think in terms of acronyms. My acronym for ADHD is HIDE, because that's what you want to do when an ADHD kid comes to your house. And so think of H is for hyperactivity, I is for impulsivity, D is for distractibility and disorganization, and E is for emotional lability. And you say, no, Gay, there's no criteria of emotional lability in the criteria. And I say, well, I'll tell you what the problem is with that. Actually, it's there. If you ever read that text part of the DSM, it's there. So it's the HIDE symptoms, and then think of the three Ps, Carlson's three Ps. Is the condition persistent? Is it pervasive, and is it impairing? And that's probably true for any condition you want to come up with, a headache, ADHD, whatever if it's persistent, pervasive, and impairing, you need to take it seriously. ADHD often co-occurs with oppositional defiant and conduct disorder, mood and anxiety disorders, learning and language disorders. And so that's kind of the shorthand for it. Now, it has a long and august history. I'm going to just take it back to 1957 when a couple of pediatricians, Laufer and Denhoff, first sort of described what got put into DSM-2, which was the hyperkinetic child syndrome. And it's interesting because if you look back at their sort of seminal article in 1957, you see some very interesting descriptors. You see that in addition to the hyperactivity and the impulsivity and the poor concentration, there is a mood component, irritability, they describe. Irritability, fits of anger, easily provoked reactions of an almost volcanic intensity. Seminal to the hyperkinetic child, not in the DSM. Variability. Behavior is unpredictable. Sometimes the kid is good, sometimes the kid is bad. He's not a straight line, always hyperactive every minute. Variable. Not in the DSM. Sleep disturbance. Falls asleep at the proper time, but wakens only after a few hours, quote unquote, rampaging through the house in hyperactive, noisy, sleep-disturbing play. So that's how this condition was born. Now, we've sort of gentrified it, we've tried to operationalize it, and what we've ended up with is what we have come to know and love in the DSM-4 criteria, which are my HIDE symptoms, developmentally inappropriate levels of the hyperactivity, fidgety, on the go, driven by a motor, impulsivity, blurts out answers, has difficulty waiting in turn, intrudes and interrupts, distractibility, the trouble paying close attention to things, being disorganized, losing things. And the E, which got broken off by the developers of the 1980 DSM-3 criteria, because it cut across a number of different disorders, and they were looking for symptoms that were exclusive to hyperactivity, ADHD. And the emotionality piece occurs with a lot of different conditions. So they put it into the text as a secondary symptom. The emotionality is low frustration tolerance, sensitivity to criticism, overreactivity, unpredictable shift towards negative emotionality, very much an important part of ADHD in many children, but not all of the children. But many of you will say, but Gay, hyperactivity isn't common to all of the children, and it's not. That's why we have the inattentive type and the hyperactive impulsive type. And you'll say, well, short attention span and distractibility and poor concentration, that's not unique to ADHD. You can see it in mood disorders, you can see it in schizophrenia, you can see it in learning disorders. So although we started out, I should say although they started out with the hope that the conditions, the symptoms would be exclusive to ADHD, as time has gone along, we know that's been a pipe dream. So over the years, that E has been given various names: negative affect, affective aggression, impulsive aggression, emotional or mood lability, emotional impulsiveness, severe mood dysregulation, and manic symptoms, which is mania criteria without episodes, which is how this condition and I have gotten to be friends. Because as you study kids with bipolar disorder and manic symptoms, you realize, this emotionality piece with the ADHD can really complicate your life. We know from the MTA studies that comorbidity is very common. Well, we've known it before the MTA study, but this slide kind of shows you how large oppositional defiant disorder is as a comorbidity. And what's interesting about oppositional defiant disorder is remember I said that in 1980 that emotionality piece was broken off? Well, guess where it got put? It got put in oppositional disorder, oppositional defiant disorder. And you know what? The brain really doesn't give a poop about our DSM criteria. The brain operates the way the brain operates. And so it's not surprising that comorbidity of ADHD with oppositional defiant disorder is so common, because that the wiring for the kids that have that low frustration tolerance and the explosive oppositional behavior is very much, I think, a part of the same syndrome that was originally defined in that hyperkinetic child syndrome. As you also know, part of the reason that this condition went from being hyperactivity to ADHD and the attention piece became the core symptom was because kids sort of develop out of the hyperactivity part, but the inattention part persists. So if you look at the course of ADHD, you see that the inattention persists with age. The hyperactivity declines, though it's is less than it is in childhood, it's still at developmentally inappropriate levels. And the impulsivity also diminishes somewhat in age and goes from being physically hyperactive, where you sort of snatch the toy out of somebody's hand, to being verbally hyperactive, where your mouth is in motion before your brain is in gear. And all of that time you're thinking about how is this matching to this child's gender, age, and developmental level. And that's what makes ADHD a developmental disorder. And that's not true for bipolar disorder. So the outcome of ADHD is there's a variable outcome. One way of looking at it is some of the kids have a developmental delay. This has been shown actually in some of the imaging, long-term imaging studies, where over time the brain seems to sort of catch up with where it ought to be, so to speak. And developmentally, about 30% of people outgrow their ADHD symptoms. It isn't clear to me whether they completely outgrow the symptoms or whether the square peg finds a square hole, that you find a niche, you do something that's interesting to you, and so your symptoms appear to be attenuated. The fact is, a significant number of people outgrow it. There's the continual display bunch of people that continue to be obviously symptomatic, This takes a toll on kids academically. 40% of them will remain symptomatic. They have poor academic outcomes, but still they manage to have a somewhat semblance of normality as adults. The worst outcome is the developmental decay outcome, and that's the development of more serious antisocial and substance abuse disorders. Russ Barkley, with whom I was giving a talk last week, did a really nice discussion of his follow-up studies of the Milwaukee Project and looking at adult hyperactivity people that he saw when he was at the University of Massachusetts. He said that looking at all of his data, there are no predictors of outcome, at least for his hyperkinetic symptom kids. Certainly, from a clinical standpoint, you just have to think that kids with irritable, aggressive temperaments and more aggression, kids with worse executive function problems, people with more family psychopathology are more likely to end up in this core terrible outcome group, but it may well be a genetic variant and that these other things are just covariates. In terms of treatment, as far as medication treatment is concerned, a meta-analysis of almost 30 studies of over 25 years, comprising almost 5,000 kids, indicates the best effect size. I guess when this translated, the little highlighter there didn't hit the nail on the head, did it? Anyway, the amphetamine has the best effect size. As you know, the closer the effect size is to 1, the better the effect size is, the more robust the finding is in terms of treatment efficacy. Methylphenidate is a close second. Atomoxetine and guanfacine are not too bad, but they don't have the same robust effect size as the stimulants do. I put this in, the diet without additives, because there's been a lot of press. There's been a couple of really good studies looking at the impact of diet on people with ADHD and whether additives make a difference. And in fact, it may make a difference in some kids, but the effect size of the difference is very tiny. And I can tell you as a child and adolescent psychiatrist, by the time somebody beats their way to my doors, if diets were going to help, they would have helped. The final thing I want you to remember about ADHD is normalizing. So many times when we sell treatment to parents and teachers, we say, oh, 70 to 80% of people respond. And that's true, 70 to 80 people do respond. But response is not the same as a recovery. And so a sizable number of kids are still significantly symptomatic, even when you treat them. And so you can see here that compared to a control sample, in the MTA study, which Dr. Pelham contributed his wonderful summer treatment program that you continue with here, even with the summer treatment program, even with the kids getting wonderful parent training, even with a teacher consultant going into the classroom, even with wonderful ADHD medication management, 2/3 of the kids normalized. And if you just looked at really good medication treatment alone, only half the kids normalized. And if you looked at just behavioral treatment alone, 1/3 of the kids normalized. And if you look at community treatment, only 1/4 of them normalize. So it's really important when you treat parents to let them know that the child will likely improve, but perfection may not be, who of us has perfect kids, but even having a completely normal child is not going to necessarily be the outcome. Now, remember I said in the beginning that ADHD comes in mild, moderate, and severe forms. Well, this is important in terms of treatment, because if you've got mild ADHD, and I consider it mild when the onset isn't picked up until later, like in elementary school, it's not pervasive in terms of a child can be often managed in more structured environments with accommodations. What you see is you still have a handicapping condition. The condition worsens in secondary school. The kid crashes and burns because he just doesn't have the organizational skills he needs to have. But the fact is many kids can manage to tread water until that time. The comorbidity, this is often uncomplicated with comorbidity. So the problem with this form is it really shows up more in later elementary school and junior high school. The moderate type of what I call moderate is showing up already in preschool. It's apparent in school and at home. Untreated, the disorganization and defiance really become more of a problem. And this type is often comorbid with learning and language disorders, oppositional, defiant, and anxiety and mood disorders. The worst kids have severe ADHD. This type of ADHD is often apparent even in utero. It's apparent everywhere and anywhere. Aggression, peer problems, drug abuse are clear complications, and again, the comorbidities that we've come to know and love. In terms of treatment, the mild forms, as I said, you can often get away with behavioral treatment, with structure in the classroom. If the above strategies change, you can then intervene with more stringent behavioral and medication treatments. And the therapy goals, the psychotherapy goals, are psychoeducation, organizational skills, and self-esteem help. When child psychiatrists get more involved, we're talking about moderate severity. We're talking about the kid usually needs to be classified. He may be able to get away with a regular classroom. Behavior modification is definitely needed. Medication is usually needed during the day and after school. And again, the same sorts of goals are concerned. The severe ADHD types are the types that we see in our inpatient service. Paul, who's one of my nurses, will tell you, and I will certainly tell you, that many of the kids that we see on our inpatient unit have severe ADHD. I remember having a conversation with a couple of my colleagues who don't have inpatient services, who are ADHD experts, and they were astounded. They said, that can't be ADHD if they're on an inpatient service. Well, I can tell you that these kids assuredly do have ADHD. It is very severe. These kids need a special education classroom. They sometimes need hospitalization. They need behavior modification, social skills treatment, mental health treatment. They need medications. They usually need more than stimulant medications. They need the whole panoply of things that we throw at them. And their therapy goals are usually decreased aggression, anger control, and mood stabilization. It doesn't take a rocket scientist to figure out that it is that severe form that's most commonly confused with bipolar disorder. So now we're going to talk about manic depression or bipolar disorder. So I gave you my HIDE acronym. I'm going to give you my HYPERS acronym for the manic episode in mania, because a manic person is very hyper. The H is for hyperactivity. Classically defined, this is goal-directed. It is not the Brownian movement that you see in a kid with ADHD. The I is for irritability. These are explosive people, and that explosiveness certainly cuts across a lot of different disorders. The P is to talk about psychosis or grandiosity. One of the cardinal symptoms of mania is to be extremely grandiose, to have an inflated self-esteem, which can sometimes develop into psychotic proportions. Elated and expansive mood is another cardinal symptom. Rapid speech, racing thoughts. When you're manic, everything is on overdrive. You're moving fast, you're thinking fast, you're talking fast. You feel like you can jump across, jump tall buildings in a single bound. And as far as sleep is concerned, you don't need it, you don't want it. Who wants to waste time in bed? It's not that you're tossing and turning trying to get to sleep. You are full of energy, you don't need to sleep. D is for depression. DUMPS is my acronym for that. I always think about the joke. Lady says, whenever I'm depressed, whenever I'm down in the dumps, I get a new hat. And her friend says, yeah, I wondered where you got those from. Joke. Okay, down in the dumps, hat, okay. D is for definite personality change of dysphoria and depression. U is for an undeniable drop in grades, because there is a clear cognitive piece to depression. You're unable to concentrate well and you're unmotivated. M is for morbid and suicidal thinking. P is for pessimism, looking at the world through poop-colored glasses. And S is for somatic symptoms. These kids are frequently in the nurse's office. They're frequently in the pediatrician's office with lots of aches and pains. You can have mania resulting from illness, from drugs, in which case it's called secondary mania. It can be superimposed on all sorts of other conditions, just like you can have poison ivy and measles. There's no, just because you have one rash doesn't mean you're not going to be able to get another one. Just because you have bipolar disorder doesn't mean you can't have another psychiatric disorder. But for those of us who view this condition in the narrower view, the symptoms have to occur concurrently in episodes, and the episodes have to last at least a week for mania and 2 weeks for depression. So if we look at bipolar I disorder, mania is the cardinal mood state. You can be a little bit depressed, you could be very depressed, or have no depression at all. But if you have a manic episode, you have bipolar I disorder. And that mania has to, as I said, last at least a week. Bipolar II disorder, the abiding mood state is depression. It's punctuated by periods of being accelerated and more energetic and happier, hypomania. But it's not the hypomania that's getting you in trouble, it's the depression that's getting you into trouble. And like all of DSM, there's a not otherwise specified category, and that's kind of a wastebasket, which people have tried to operationalize. The folks in Pittsburgh at Brown and UCLA, who've been doing a follow-up study now for a number of years, have tried to operationalize the bipolar NOS to say that if you have a day, at least a day here and there of manic symptoms, you may be at risk for developing a full-blown manic episode, and so that's what they want to talk about with bipolar not otherwise specified. In terms of the phenomenology of bipolar disorder, depending on how comorbid it is with ADHD, and the comorbidity is often very high in pre-adolescent onsets, anywhere from 70 to 90% of people, kids who are called bipolar, have co-occurring ADHD. You see that that co-occurrence goes down in adolescence, so an adolescent onset bipolar kid, 50-50 chance that he'll have co-occurring ADHD. And by the time you get to a young adult onset, the likelihood of your having had a bipolar, having had an ADHD comorbidity declines considerably. The more ADHD you have, the more likely you are to have male preponderance. So this is the comorbidity, no comorbidity businesses. I wanted to say something about it. In adults, in fact, one of the reasons that I got interested in manic-depressive illness, bipolar disorder, was as a resident, I was amazed to watch people who seemed like they were normal, rational, put their pants on one leg at a time, reasonable people go stark raving mad. If you haven't seen that in your lifetime, it is simply amazing to behold. And then after a tear, which can go on for several weeks to several months, in which, as I say, they are stark raving mad, they can regroup, calm down, and go back to normal or become profoundly depressed. But the fact is that clear episodicity in an otherwise normal person is just stunning when you see it. You don't ever see that in children. Ever. You sometimes see it in adolescents, and you more often see it in young adults and people over the age of 30. So when I say no comorbidity, I mean that you are squeaky clean, you don't have another condition, you go stark raving mad, then you come back to your premorbid state. And that 8% business, that's because, frankly, the kitty SADS is used to do a lot of the research, and the kitty SADS does not ascertain a lot of important disorders like autism and autism spectrum disorders, learning and language disorders, etc. So I think a lot of those kids, the 8%, really have something else wrong. It just didn't happen to be picked up by the kitty SADS. But anyway, the male preponderance, the only point I wanted to make with that was that men, in adults, there's no gender difference between males and females. In children with pre-adolescent bipolar disorder, there's a male preponderance, which seems to go along with the ADHD. The other thing that's interesting about early onset bipolar disorder, very early onset bipolar disorder, is the duration of the episode. In adults and people over the age of 30, the episodes usually last, the manic episodes usually last for 3 to 4 months. Over 80% have had a remission. Their episode is done by 6 months. For the adolescent and young adult onsets, about 2/3 of them, episode is done. 2/3 are done by 6 months. If you look at Barbara Geller's data, if you look at Barbara Geller's data of the kids that she calls manic, even at a year, only a third of the kids have remitted. So this pre-pubertal bipolar disorder thing is really quite different from this group of adolescent and adult bipolar people. What about treatment? Two things speakers always need to do. One of them is disclose conflicts of interest. The other is to tell you what they're going to talk about, which is off-label. And this is to tell you what's on-label and what's off-label. On the left, you see all of the medications that have been used as treatments for an acute manic episode and that have been approved for adults. And on the right, you see what's been approved for kids. Lithium has been approved for adolescents. It was grandfathered in a time when nobody had to do any research. Olanzapine and risperidone and quetiapine and aripiprazole have been approved, well, the last three have been approved down to the age of 10, Zyprexa or olanzapine, only in adolescents because of a quirk in when they were asked to do the study. Ziprasidone or Geodon has had a positive study, but for a variety of reasons has not been approved by the FDA. Now, you may well ask, what do you mean approved down to the age of 10? What does that mean? What that means was that we had a consensus conference back in 2002. All of us bipolar mavens got together, kicked in uncomfortable places, rolled around on the floor, screamed and yelled at each other, and tried to come to a consensus about the point at which you can identify bipolar disorder as it occurs in adults. And the reason for that has to do with quirks of FDA labeling. Tom Lofgren, who is the FDA person who does all of this stuff and who was at this meeting, and who's a very nice man, I have to tell you, said, listen, if you want to get these treatments approved, we're not interested in this peculiar bipolar variant with different criteria. We want bipolar disorder to look like it does in adults. At what age would you say you start to see that? And the conclusion that people came to was the age of 10. There were some people who said younger, but we agreed on the age of 10. So that when the FDA put out their calls for studies for the drug companies to do, age 10 was the Maginot line. Now it's interesting because if you look at drug responses, you remember those nice, robust effect sizes that I gave you for stimulant and even non-stimulant treatments of people for ADHD. This is how the effect sizes shake out for early onset mania in kids. The effect size of mood stabilizers is 0.2. That's don't even get out of the house for an effect size, right? That's just not even worth a discussion. And by mood stabilizers, I mean things like lithium and the anticonvulsants. Second generation antipsychotics, which was the risperidone and aripiprazole and quetiapine and all those guys, the effect size is 0.65, much more respectable. Interestingly, the effect sizes in adults for mood stabilizers is obviously better. For the second generation antipsychotics isn't quite as good. Even then, the effect size is not anything to write home about. But understand that all of the drug studies that have been done to capture these effect sizes are very short-term studies, 3 to 4 weeks. And so what they're trying to do is knock the thing down and get a, I'm blocking on the term that they use, a signal. Get a signal that the thing is going to work. We're not talking about cure at this point. So the effect sizes, I can sort of explain them away a little bit, but still, they're nothing to write home about. So now we're going to talk about manic depression or emotional lability. Are the kids with rages, are the kids that are being called pre-adolescent, pre-pubertal manic, do they have manic depressive illness or do they have something else? And you've been to Norway, Wendy, you were telling me this little guy is in that park, I'm blocking the name of the park where, yeah, okay, so you're Norwegian, okay, good. Okay, so you know this little boy.
I think he's the most famous statue in Norway.
Yes, he's wonderful, isn't he? I saw him and I fell in love. I said, he's my kid on my inpatient service, right? So those are the children on my inpatient service. They're bigger. They pack a bigger wallop, but they're that kid. Okay, so now let's sort of talk about some clinical cases. How would you describe a 6.5-year-old girl who falls to the floor crying and tantruming I want to die, kill me, when anything happens she doesn't like. This can last for several hours, only happens at home. Her father, who's a big guy, 6'4", very abusive, she's witnessed him say, I'm going to kill your mother. How about this kid? 8-year-old, third-grade boy in a special ed class with mood swings. He throws chairs, sweeps stuff off of desks, he attacks the staff. Chronically hyperactive, impulsive, irritable at home and at school. Says what makes him mad is when my mom tells me to do stuff I don't want to do, and too much work in school, which is too hard, and I need help, and the teacher says, wait. Well, what did these kids have in common? Well, both had been given a diagnosis of bipolar disorder by a reputable child psychiatrist. The first kid had been given a diagnosis of a mixed episode, certainly recognized that there was some depressive symptoms in there. Second kid had been called manic. Both had a first or second degree relative with a mood disorder. Both had elevated scores on a child mania rating scale, which I'll talk about, or which Paul and I will talk about in a little while. And depending on how you interpret the kitty SADs, the Schedule for Affective Disorder and Schizophrenia for Children, they could meet criteria for current or lifetime bipolar I disorder. So given how common severe rages are, it's probably not a big surprise that over the past 5 or 6 or 7 years, the diagnosis of bipolar disorder has really taken off. And it's been the subject of a good deal of press. Part of the reason for that is, and this is really sad in a way, because when DSM-3 was born and when we developed the various structured and semi-structured interviews that we use to try to ascertain symptoms, the idea was that we wanted agreement on what we were observing. We want everybody to look at this thing and say it's a table. We don't want some people to call it a peanut butter sandwich and other people to call it a mousse. We want everybody to say that this is a table. And the criteria for a table is it's got to be flat, and it's got to have 4 legs, and it's got to hold stuff. It doesn't matter how big it is or how small it is, but that's a definition of a table. And we all agree to that. Well, everybody agrees to the criteria for DSM. Nevertheless, we have very different ways that those criteria are interpreted. And so at Washington University, Barbara Geller says elation and grandiosity. Well, elation is being silly. If a kid's being silly, he's elated. If he brags and he says to the teacher, you know, you're full of crap, I can do this, you know, course better than you, or tells the principal to go, you know, put it where the sun don't shine, he's called grandiose, because that's just not an appropriate thing to say in adults. And it is inappropriate, but whether or not bragging is grandiose is subject to discussion. She defines ultra-rapid cycles as somebody who has a severe rage. If you rant and rave like that little girl did for several hours at a time, she calls that an ultra-rapid cycle. Not everybody agrees to that. Community uses rages as synonymous with bipolar disorder. The course and outcome of bipolar youth study that I mentioned before, the multi-site study, has their way of defining bipolar NOS. My colleagues at Mass General don't care whether the kid's got elation or grandiosity. If you have severe irritability, the very severe irritability, they say, is really characteristic of mania. My colleague Ellen Liebenluft at NIMH has tried to help out with this bipolar controversy. She talks about narrow phenotype classic bipolar disorder versus severe mood dysregulation. My own quirk about bipolar disorder is I have to have a number of informants tell me that the child is having a manic episode. If a child only has mania at home and is okay in school, in my view, that is not mania. And in fact, we have some data, and Wendy will be interested in this, we have some data that kids who look quote unquote manic at home and in fact are okay in school are much more likely to have an anxiety disorder. So the fact is everybody swears on the DSM Bible, but like the Bible, everybody interprets it in a different way. So where do ADHD and manic symptoms overlap, or how do interpretations differ? Well, a person who is elevated and feeling no pain and really, on top of the world can certainly behave in a silly way, but we know that ADHD kids can often be class clowns and be attention-seeking and silly. Irritability and low frustration tolerance, there's no difference between those two things. Goal-directed activity that you see in mania, well, hyperactive kids are on the go. I don't know that their activity is necessarily goal-directed. That's one of the problems. But if you're not really asking about goal-directedness, you can say they've got mania hyperactivity. Reduced need for sleep. Well, ADHD kids have trouble getting to bed at night. Their brains haven't wound down. They're kind of nosy parkers. They want to know what's going on. The difference is they often are very cranky the next day, and if they're not cranky the next day, they're cranky the day after that. Inflated self-esteem and grandiosity. I told you about one person's interpretation. Betsy Hosa has a concept that she calls a positive illusory bias that ADHD kids have, where they don't quite recognize that they're not the most popular kid in the class, or that they aren't really going to pass this course. And so they actually, you might say they have an inflated self-esteem. I think they're defensive, but the fact remains, if you don't know how to interview a kid, you can call that grandiose. Flight of ideas. If you've ever heard somebody who's manic and they're talking a mile a minute, their thoughts are going 1, 3, 5, 7, 9 instead of 1, 2, 3, 4, 5, 6, 7, 8, 9. That kind of flight of ideas. Many kids with ADHD have pragmatic language problems. Somewhere between 40 and 50% of ADHD kids have language disorders. And being off topic and poor pragmatic language is one of the types of language problems they have. So you have an ADHD kid with pragmatic language problems, you can see why somebody might get mixed up with a person who's manic. Engaging in activities with a high potential for bad outcomes, well, ADHD kids are impulsive and reckless. You go sliding down the banister thinking that you're going to, end up in a pile of laundry, and isn't that going to be funny? And the fact is there's no laundry there and you end up breaking your arm or something like that. Well, you can say that that person wasn't looking to sustain pain. They were looking to have fun. So again, just looking at the symptoms, it's really difficult sometimes to make a distinction between mania and ADHD. So what it really comes down to is, and I can tell you this from a personal experience because I went from being a fully trained adult psychiatry person, spent a year at NIMH on the affective disorders unit, got my calling, saw the light, decided to go into child psychiatry. My first experience in child psychiatry was on a children's inpatient unit. And my God, I remember saying, God, these kids are like little manic kids. The difference is that mania is supposed to be episodic. You're not always like that. And ADHD as a developmental disorder has a very early age of onset. The difficulty is that the DSM that we all swear by did a very poor job of defining episodes. And so if the only way you really know mania is by reading the DSM, you have completely screwed up the template. The symptoms in a manic episode, if you read the DSM, are supposed to last at least a week. They don't define an offset. If you don't have an offset, you don't have an episode. And so many of my colleagues will say, they've been manic for at least a week. It started when they were 2 and it never stopped. It's not an episode, though, because it hasn't required a change from baseline, and there's no offset. And one of the things that makes kids so difficult to study is the baseline is moving. How do you know what a premorbid self is when a kid is 2? I'm not even sure I know what a premorbid self is when a kid is 6, because development is such a moving target. You know, well, some of you who know me know, who I am and what I'm like, and I talk and I move and so forth and so on, but I'm not, and don't you say a word, too outlandish in what I do. If I showed up at this presentation with, a really short skirt and a really plunging neckline and, pink lipstick and orange hair, you'd say, oh my God, that's not the gay Carlson I saw a few weeks ago. Who spiked her punch? And if you heard that I'd been like that for the last several weeks, you'd say, oh my God, she's having a manic episode. So you know who I am, and you can tell what the distinction is. Another problem with the DSM is they didn't make any provision for comorbidities with anything, let alone comorbidities with ADHD. People define the symptoms different. And so we really ended up with a mess because of DSM. So things that have been done to try to clarify things, Ellen Liebenluft, that I mentioned before, has tried to examine kids with a chronically irritable explosive state and contrast it with adult-like bipolar disorder where the episodes occur with an onset and an offset, which she takes a great deal of pain to define. And what she has found so far is that there is a real difference between this chronically irritable explosive bunch of people versus the more classic phenotype. And her data would say that family history is different, response to treatment is different, outcome is different, and the brain circuitry is different. So it seems like there's some pretty good evidence that chronically irritable explosive kids are not the classic bipolar types. So her definition of this chronically irritable explosive bunch of kids, severe mood dysregulation, is abnormal anger or sadness most days, severe enough to be noticeable by parents, teachers, or peers, markedly increased reactivity to negative emotional stimuli. That's a fancy way of saying the kid gets mightily ticked off with for very trivial reasons. It should happen several times a week and at least for a circumscribed period of time. There are co-occurring ADHD symptoms and the onset is under the age of 12. Because of the way people analyze their data, they look at it in a sort of linear way. What percent of people have ADHD? What percent have ODD? What percent have anxiety? What percent have depression? So she found that, something like 60 to 70% of her kids had ADHD, 60 to 70% of the kids had ODD, 50% had anxiety, et cetera, et cetera, et cetera. These are the severe mood dysregulation kids. So I wrote to her, I said, Ellen, how many kids have comorbid ADHD and ODD? And how does that differ from your bipolar group? And the answer is 80% of her kids with severe mood dysregulation have ADHD and ODD. That comorbidity really occupies 80% compared to the bipolar group where it was like about 20 to 25%. So it's the comorbidity. Remember back in the Loffer-Denhoff, that variability, explosive rampaging through the house. Remember in the E and Hyde, that's that ADHD-ODD group of kids. So what we know about ADHD, severe mood dysregulation, and bipolar disorder in terms of epidemiology, bipolar disorder in pre-adolescence is vanishingly rare. Severe mood dysregulation occurs between about 1% and 2%. And as you can see, the severe mood dysregulation is going to be just much more common than a true kid with bipolar disorder. So anyway, the DSM-5 committee has tried to rectify or is trying to rectify their past sins. And they have proposed the following changes to mania and hypomania. First of all, they're going to call a distinct period of elated, expansive, and irritable mood to occur most of the day, every day. So this isn't just, you have a few hours of being elated. It's got to be most of the day, every day for at least a week. It's got to be a noticeable change from your usual behavior. The B symptoms, the other symptoms of mania, have to co-occur. The A symptoms are expansive, irritable, or elated mood, and the B symptoms are the fast talking, the can't sleep, the pleasure seeking, the grandiosity. The B criteria have to begin or worsen at the same time as the mood change. Antidepressant-induced treatment has got to last beyond just the physiological effects of the drug, and we'll actually talk about that in one of the cases we talk about. And kids with chronic severe irritability and explosive outbursts may be given a diagnosis of disruptive mood dysregulation disorder. This was tempered dysregulation disorder with dysphoria a little while ago, but not only did that get a big backlash about the tempered dysregulation, nobody could say tempered dysregulation disorder with dysphoria 5 times fast. So in fact, the disruptive mood dysregulation disorder is very much patterned on Dr. Liebenluft's data, but Ellen's data comes from a rarefied sample of kids at NIMH. This is now out to pasture. They're doing field trials to see whether in fact this, sings in Peoria. The problem, of course, is that mood dysregulation disorder, disruptive dysregulation disorder, does not solve all the problems. Anybody that works in a clinic recognizes the fact that you see a lot of explosive kids, and it really is difficult to know what to call them. Insurance companies don't like the idea that they've got ADHD. ODD doesn't cut any ice. It's very difficult to give somebody two simultaneous diagnoses. And so it's not surprising that you've backed into calling kids bipolar, both to get their condition paid for and also to convey the seriousness of the problems that these kids can manifest. So we need a home for kids like that. The question is going to be whether this new diagnosis is going to be a good home. As it turns out, and we've done this research on our inpatient service, there are some kids that have explosive outbursts without being irritable in between. They're just fine, thank you very much, until you tell them they can't do what they want, and then they go from 0 to 60. They're not irritable in between. There are a number of rule-outs to dysregulation, mood disruptive dysregulation disorder, and those rule-outs are depression, mania, PTSD, pervasive developmental disorder. The problem is a lot of kids with those problems have explosive outbursts. My thought, and this gets a lot of traction in the clinical community, doesn't get much traction with the DSM-5 committee, but my idea is that I think we should have explosive outbursts as a modifier. So you can have a kid with a major depressive episode with explosive outbursts. You could have a kid with PTSD, like the little girl who's witnessed her father being abusive to her mother. You could have PTSD with explosive outbursts. You could have ADHD or mania or anything you want with explosive outbursts. And that way, you'd be able to look at the condition with and without explosive outbursts, see if the explosive outbursts change your circuitry and brain chemistry. So just to look really quickly at how frequently you see this DMDD diagnosis, if you have just irritable mood with explosive behavior, in our inpatient unit, almost 90% of those kids had ADHD. Half of them had anxiety problems or depression. 100% were oppositional. Almost 30% had a tic disorder. About 25% had a pervasive developmental disorder. And a lot of them had manic symptoms. Okay? In the outpatient department, the rates are different, but the gist of it is irritable behavior with explosive outbursts cuts across a lot of different diagnoses. And the converse is true too. If you look at a population of outpatient kids with ADHD, 57% will have parents complaining about explosive outbursts. Oppositional defiant disorder, 3/4 of them. Any bipolar disorder, a lot of parents will say the kids have explosive outbursts. Not all of them do, but a sizable number of them do. Well, now we're going to talk about those manic symptoms. Remember I said a high percentage of those kids with the DMDD have a high rate of manic symptoms? But one of the things that we've looked at our clinic and our inpatient service is parent endorsement of a manic symptom rating scale. One of the things that we know about parents endorsing manic symptoms, or even going and doing a structured interview like the Kitty SADS is, parent-child agreement is abysmal. The kappa is 0.02. That's not the significance, that's the kappa between the parent and the child. If you look at parent-teacher agreement, the correlation is about 0.23 to 0.28, pretty much garden variety, parent-teacher agreement on almost anything you want to name. So the fact is the assessment needs to go beyond ascertaining manic symptoms. On the other hand, when you get somebody endorsing manic symptoms, you find that they contribute independent of other diagnoses to significant social impairment. So ADHD kids who have that mood lability or manic symptoms, when you do follow-up studies on them, in fact, you find that those symptoms are pretty hardwired and confer extra disability. And I think that they probably are proxies for a behavior and emotion comorbidity that we've known since Mike Rutter's Isle of Wight study has a worse outcome than either externalizing or internalizing disorders alone. So just to give you some data on manic symptoms without episodes, irritable, elated mood, hyperactivity, impulsivity, et cetera, without episodes, manic symptoms. 10% of an adolescent population that I studied when I was in Columbia, Missouri. 6% of 1,700 teenagers that Peter Lewinson studied in Oregon. Very common. Very few of those people ended up having true mania. In outpatient clinic samples, 43% of a multi-site study of 3,300 kids, 43% had manic symptoms in the outpatient clinic. 25% of people in my outpatient clinic have manic symptoms. 70% of kids on my inpatient unit have manic symptoms. And as you can see over there to the right, very few of them have mania. So the fact remains, manic symptoms are very common. True bipolar disorder is rare. Now you can say, well, but wait a minute, Gay, what happens to those kids with manic symptoms? Do they develop bipolar disorder? And I can actually answer that question. If you look at Peter Lewinson's data, because he's got quite a sizable sample there, and he's followed them up now to their late 20s, of the kids that had hypomanic symptoms or maybe a bipolar NOS, very few of them converted, 0.1%, okay? That's less than population rates, okay? What happened to those people that you might have considered to be at risk is, as young adults, they had a mood disorder. They had depression and anxiety. They did not have bipolar disorder. And this has been true in a number of other epidemiologic studies where kids have been viewed as adolescents and then have been followed up to young adulthood. Looking at kids with hyperactivity, and there have been a number of long-term follow-up studies of kids who were hyperactive. We weren't worried at this point about the ADHD criteria, so you're going to assume that included in those hyperactive kids are going to be some of those people with emotional lability. If that ADHD with emotional lability is going to put you at risk for bipolar disorder, in adult studies of these ADHD people, you would expect to see higher rates of bipolar disorder. Population rates of mania are between 1% and 2%. You'd expect to see higher rates than that. Well, you don't see them. You don't see them in the Klein and Menuza studies. You don't see it in Jan Loney, and I did a paper a number of years ago looking at her follow-up study. You don't see it in Phil Hazel's study in Australia. You don't see it, and I don't put Russ Barkley's on here because I just heard him, but anyway, you don't hear it in Russ Barkley's follow-up study. None of these, you do not find, frequently you don't find anybody, you certainly don't find higher than population rates of bipolar disorder. How about irritable kids? If severe irritability is a proxy for mania, what happens to kids with severe irritability? Interestingly enough, most of us were trained to think that kids with oppositional defiant disorder all grew up to become conduct disordered. Not true. Turns out a sizable number of them end up having a mood disorder. It's depression, okay? So there's some mood connection here, but it's not a bipolar connection. And that's been shown in a number of different ways. How about looking at aggressive kids? There have been a number of follow-up studies of kids with severe aggression. Again, continued problems with aggression. Aggressive preschool kids, high rates of aggression in elementary school. If you've got elementary school severe aggression, you're more likely to be an adolescent with aggression. If you're an adolescent with aggression, you're more likely to be an adult with aggression. Fairly stable trait. They don't develop manic-depressive illness. Okay, so how about a high-risk population? Okay, I've studied a high-risk population, a follow-up study. It's gone on at NIMH for a long time. Kids that were offspring of parents who had a depression or bipolar disorder. These were kids that were studied by Marion Radke-Yarrow from the age of 2.5 on. My colleague Stephanie Meyer, for her PhD thesis, followed them up as young adults. In this high-risk sample, if you found a group of kids who had the CBCL phenotype, which some people thought were bipolar risk groups. The CBCL bipolar phenotype is elevated anxiety, elevated attention, hyperactivity, elevated aggression, elevated 1.5 to 2 standard deviations. That's the CBCL juvenile bipolar phenotype. We looked at kids who had that phenotype to see what became of them as young adults. And as young adults, it turned out that they did have pretty high rates of bipolar disorder, odds ratio of 8 compared to kids without that phenotype. you think you've discovered nirvana. Unfortunately, they also had very high rates of cluster B personality disorders and very, very high rates of comorbid anxiety, depression, and behavior disorders. So whatever this is it's hardwired. It does not become classic manic depressive illness. So children with manic symptoms do not develop disproportionate rates of bipolar disorder. The emotional lability in ADHD is not prodromal mania. Follow-up studies of severe mood dysregulation so far have revealed a depressed, not bipolar outcome. Follow-up studies of kids with rages do not reveal higher rates of bipolar I disorder. And high-risk kids with ADHD and mood lability in childhood continue to show that constellation of symptoms in adulthood. So the combination of externalizing ADHD, ODD symptoms and severe mood dysregulation or serious mood lability or manic symptoms, whatever you want to call it, isn't new. We've renamed it. It's noxious, impairing, often enduring. It's, I think, accounting for a sizable percentage of kids being called bipolar. Researchers are finally realizing that emotional lability is an important construct. Intervention and prevention are clearly justified. But classic episodic bipolar disorder does not appear to be an outcome in most cases. And there are important treatment implications of that, because ADHD and mania have some similarities, but they have some differences. They're both chronic, heritable, require medication and psychosocial treatment. They have similar comorbidities. Their genetics are different. The episode, mania should occur in episodes, not just be severe rages. The treatment is different. And if there's a diagnostic mistake, what happens is if you say, this raging kid has bipolar disorder, I can hear the brain slam shut. Bam, bam, bam. Solution, put it away. We don't have to think about what's wrong with this child. So people think they have a premature closure to a significant diagnostic problem. Clinicians don't look for other conditions that need to be identified and treated. Everyone assumes there'll be a connection to bipolar disorder in adulthood, and that medications for bipolar disorder will clean the kid up nice. Even worse, they won't use medications that might be helpful. So to go back to our effect sizes again, many of the kids, I think, getting into those childhood mania studies have ADHD and severe mood dysregulation. Not a big surprise that the effect size is so poor. It's also not a surprise that the effect size of the second-generation antipsychotics are good. They're like aspirin in a fever. Aspirin doesn't care what your fevers do to it, just reduces fevers. And the atypicals don't care why you've got irritable aggression. They're tranquilizers, for God's sakes. They calm you down whether you've got irritability from autism or irritability from mania. So it's not surprising that they're effective. What's interesting and what's problematic is if you don't pay attention to the fact that some of those kids may have ADHD and aggression, you aren't going to use medications that are helpful for ADHD, like the stimulants. And we know that the effect size for stimulants and aggression is pretty damn good. It's in fact better than any of the other things that I'm showing you. So here's the rub that we've had for many years. People who have worried that these raging kids have bipolar disorder have not used stimulants. And so a few of us have had to sort of be pioneers and go out there and do that. And at this point, there have been 6 systematic studies that have found stimulants not only not harmful, but possibly helpful. One study, in fact, found stimulants to be protective in kids with ADHD, and it kept them from developing what she called bipolar disorder. One study of high-risk kids found that stimulant-treated kids did not become manic any sooner than those without stimulant treatments. There are many kids who can't tolerate stimulants, but they don't necessarily develop bipolar disorder. And I think the biggest problem with stimulants is in the severe kids, like the ones that Paul and I see in our inpatient unit, the drugs just don't work well enough. So here's some data from the MTA study, where, as you know, kids were followed with stimulant treatment and everything that they could have over the course of time. Looking from baseline to follow-up, if you look at a group of kids that have that juvenile bipolar disorder phenotype, elevated depression and ADHD symptoms and aggression, what you see is that top line there. They start out more severe, and they end up more severe than the uncomplicated ADHD kids, but the slope is exactly the same. So the kids get better. They don't normalize. They don't get as good as the uncomplicated kids, but they get better. So it's kind of like if you've got a fever of 101 and you take your aspirin, your temperature will go down to 98.6. If you have a fever of 105 and take your aspirin, your fever might get better. It might go down to 103, but you're still sick. And so what happens with these kids with the stimulants is the stimulants help. They don't help enough. Now, if you look at the mood stabilizers in kids with manic symptoms, what you see is a very unimpressive response. Here's divalproex, and what you see is the yellow line is divalproex, and the red line is placebo, and there is not a whit of difference between drug and placebo. And I can promise you, Abbott Laboratories has looked at this 6 ways from Sunday, and there is no way they can get any kind of response out of their drug. On the other hand, this is a study with divalproex done by my colleague Joe Blader, who, he didn't say it that way, but this is how I say it. He's looking at kids with ADHD and aggression. He gets their ADHD stabilized with their stimulant, and then he randomizes them to placebo and divalproex, and lo and behold, there is some difference. The divalproex confers a little help over placebo. So it may be that there is a mood stabilizing component of the divalproex. It just is like peeing on the Chicago fire if you give it to a kid with untreated ADHD. So the bottom line is that the treatment implications are really quite significant. That the mood stabilizers, the lithiums, the depakotes, the antipsychotics, you can use in mania or bipolar disorder, you can use them in aggression, you can use them in autism. There's nothing diagnostically specific about it. The difference is if you don't understand what the kid really has as far as his aggressive and raging and ADHD type behaviors are concerned, you're going to miss some really important things that need to be treated. So you're not going to give the child ADHD medications, and you're not going to give him the kind of therapy that he needs. If he's got autism, you're not going to give him the right IEP. If he's got PTSD, you're not going to get him out of the house. So it's really important that that brain doesn't slam shut when you've got a raging kid deciding the kid's got bipolar disorder. So what you should know about ADHD is that many kids diagnosed with mania and bipolar disorder probably have ADHD and mood lability. That said, it's difficult to distinguish them in a single assessment. And why you should care is because the treatment and outcome are different. In my humble opinion, it's important to be candid with parents about that. All things being equal, I treat the ADHD first, but I warn parents that a different approach might be needed. The biggest problem, as I said, is I find that our treatments are not effective enough. So, thank you.